Welcome. The American Association of Neurological Surgeons is accredited by the Accreditation Council for Continuing Medical Education to provide continuing medical education for physicians. The AANS designates this live activity for a maximum of one AMA PRA Credit 1 category. As a provider accredited by the Accreditation Council for Continuing Medical Education, the AANS must ensure balance, independence, objectivity, and scientific rigor in all its sponsored educational activities. In accordance with the ACCME standards for integrity and independence in accredited education, the AANS is required to disclose to the activity audience the relevant financial relationships of the planners, faculty, and any other individual in a position to control content of this activity. Those who have disclosed a relationship with ineligible companies are listed on the current slide. All disclosed financial relationships have been mitigated in accordance with ACCME standards. Planners, faculty, and any other individuals in control of content not listed here indicated that they have no relevant financial relationship or conflicts of interest to disclose for this activity. Credit claiming will be available in our learning management system, NeuroU. Claiming instructions are on the screen and will be shared again at the conclusion of the webinar. By the end of next week, participants will receive an email notification of enrollment to claim credit. This notification email will also include the instructions on screen for your convenience. For any issues or questions regarding claiming credit, please contact education@aans.org. Now, to get us started, I would like to introduce Dr. Hajipanias.
On behalf of the AANS CNS Tumor Section, welcome everyone. Really excited for this next webinar in our series that's going to focus on immunotherapy and targeted therapies for glioma by Dr. John DeGroot at UCSF. Dr. Yoshua Ashkenazi will introduce him more formally in a moment. I just want to remind again the group, these are CME accredited. These are all recorded. They'll be on our Tumor Section website for your viewing pleasure. And would like to also again thank the AANS for all their support in our endeavors with the Tumor Section. So thank you very much. Dr. Ashkenazi?
Thank you, everyone, again. And thank you, Dr. DeGroot, who is the Division Chief of Neuro-Oncology at UCSF and an internationally recognized leader in the field of brain immunotherapy, focused ultrasound, and targeted therapies. He obtained his medical degree at UTMB in Galveston, followed by residency at Hopkins and fellowship in neuro-oncology at UT MD Anderson. His research expertise includes drugs delivery across the blood-brain barrier using therapies such as laser ablation, focused ultrasound, therapeutic approaches to address tumor resistance, and discovery of angiogenic molecular targeted immunotherapy treatments for glioblastoma. He's been the PI of over 40 trials and a collaborator of over 80 other studies, and we're thrilled to have such a distinguished speaker with us and look forward to an enriched discussion on immunotherapies and targeted therapies in gliomas. Thank you so much, Dr. DeGroot.
Yeah, thank you. And thank you, Casas and Yoshua, and of course to AANS for inviting me to speak today. Due to the kind of time limitation, I decided to just focus primarily on immunotherapy, but happy to come back and talk about targeted therapies sometime if allowed. So go ahead and jump right in. This is my disclosure slide. Sort of as an outline today, I'm going to talk a little bit about some of the challenges in treating glioblastoma, some of the recent updates in immunotherapy, some opportunities, and then ways that I think the field is moving forward towards developing better and more effective immunotherapies for glioblastoma. Not going to really, I think everybody here knows the story, but despite decades of effort, we've not really improved the median overall survival outcome for patients with glioblastoma. And this, despite many failed phase 3 clinical trials. And you can see each trial costing $100 million. There's been billions of dollars spent on negative studies. Why is it so difficult? These don't have single tumor drivers. There's a lot of epigenetic alterations that are primary drivers. The tumor microenvironment is extremely cold. And so that has really limited the opportunities to develop better therapies there. There's really kind of, multiple different types of immunotherapy that have been looked at. I'll not going to talk about oncolytic viruses or vaccines today, but we're sort of most advanced in terms of phase 3 studies in the immune checkpoint blockade segment. But I think there's a lot of excitement and I think a lot of opportunity with CAR Ts and other cell therapies that are currently undergoing clinical trials. So sort of the most mature data really in glioma comes from some recent phase 3 clinical trials with immune checkpoint inhibitors. You can see, there's been multiple approvals across other solid tumors and other liquid tumors. But unfortunately, in glioblastoma, we've had really 3 main negative trials. This was a trial from a few years back looking at nivolumab versus bevacizumab in patients with recurrent glioblastoma, checkmate 143. And you can see on the Kaplan-Meier curve on the left, there's no improvement in the median overall survival compared to bevacizumab. Not surprising. After that study and after a phase 1 trial confirming safety of giving nivolumab in patients receiving radiation and temozolomide, there were 2 randomized open label randomized controlled clinical trials in unmethylated patients where patients received nivolumab with radiation compared to standard of care radiation temozolomide. And then a second single blind randomized controlled trial in methylated patients where nivolumab was basically added to the standard of care and compared with placebo. And this is a super short summary of that data. No improvement in median overall survival. And what I always like to sort of point out is that in unmethylated patients where temozolomide was not given, patients receiving nivolumab actually survived shorter with a significant p-value and a hazard ratio of 1.3. This is either temozolomide does have an impact in unmethylated tumors, or it's possible that there could be some harm related to the immune checkpoint blockade in this patient population. So I think it's a lot of important lessons to be learned from those studies. We recently published a upfront clinical trial of atezolizumab, which is an anti-PD-L1 study, and this was a single institution trial that we started at MD Anderson before I left, actually quite a while before I left, and Xiaopei Weathers was the PI of that study, where patients with newly diagnosed glioblastoma were basically treated with standard of care with the addition of atezolizumab. So single arm study, but what was great was it allowed us to collect a lot of rich correlative data from tumor tissue. This is probably the first study where we were able to obtain microbiome in a subset of patients. And you can see here sort of 78 patients consented and 60 were eventually enrolled. There were 4 patients that were IDH mutant that were not included in this analysis. And this is really a high-level overview of the Kaplan-Meier curve here. The median overall survival from this group was around 18 months, which we essentially said was kind of a negative trial. It's sort of very consistent with other upfront studies in glioblastoma. But we were able to do sort of a deep dive into some of the molecular sort of pre-treatment predictors of efficacy. And this is, you can see in this oncoplot of recurrent somatic mutations on the left, and with unsupervised clustering based on global gene mutation profiling, you could see that high levels of EGFR were associated with worse outcome, but PTEN mutation was actually associated with improved outcome. We also looked at the transcriptomic analysis, which you can see here. and the Kaplan-Meier curve for overall survival, comparing sort of a cluster 1 and cluster 2, sort of a better outcome group compared to worse outcome group. And if you looked at those transcriptomic programs that were associated with longer or shorter overall survival, you can see that longer overall survival was seen in tumors that were sort of enriched for interferon gamma signaling, an inflammatory response, or antigen presentation. So they also looked at the cytolytic score, sort of this box plot down here at the very bottom. The cytolytic score is sort of key immunologic features that are associated with response to immune checkpoint blockade. And you can see that those with the higher cytolytic score were associated with longer overall survival. We also looked at immune infiltration profile, and this was sort of the immune estimate immune score, or EIS, and you can see that those tumors that had this high enrichment score had a better overall survival, and we show that this was not a predictive, or excuse me, this was not a prognostic marker, because the same EIS score was not predictive of a better outcome in TCGA or in the GLASS consortium. And then we looked at the X cell immune deconvolution, and demonstrating that tumors that had high M1 to M2 ratio, those that had higher T cell CD4 effector memory signatures were more likely to have improved outcome. And interestingly, those tumors that had mesenchymal phenotype were also associated with a longer median overall survival. This is the microbiome data. So you can see that looking at alpha diversity and also beta diversity, and showing here that there are actually very specific species of microbes that were actually associated with improved outcome. And there are actually some of these microbes are actually associated with improved outcome in other diseases such as melanoma. So it's very interesting. It's not a lot of data. I think we only had 14 patients in that group, but it's still very, very interesting. And this is a multivariate hazard ratio analysis, looking at and sort of summarizing sort of what we were showing in terms of improved outcome, particularly those with the high EIS score, as you can see here, and at the bottom there, EGFR mutation, showing worse outcome. So very, very interesting data. A lot of sort of hypothesis generating studies, and I know there's a lot more studies now that are integrating microbiome analyses in their immunotherapy studies. So, what are some of the challenges that we have in the field in terms of developing an effective immunotherapy? And the people have talked about the immune privilege of the brain, which I think a lot of people have sort of discounted to not be true. And I think there's actually some good data, from other neurologic diseases, including things like autoimmune CNS diseases, multiple sclerosis, vasculitides, et cetera. And then those that are associated with antibodies, such as some of the paraneoplastic disorders, where there's a very clear effector immune response in the brain, not a positive one, but a disease-inducing one, but nonetheless an effector immune response in the brain. And of course, we also see this in the hospital for patients being treated with immune checkpoint inhibitors or other immunotherapies, where there's very clear CNS neurotoxicity driven through immune activation. and an effector immune response. So, very clear examples of the fact that the brain is not necessarily immune privileged. And I think the other data that sort of points to this is those patients who have germline mismatch repair deficiencies. This has been described now for quite some time. It's relatively rare, but those that have, for example, POL deficiency, germline POL deficiency, patients with Lynch syndrome are more likely to have a response to immune checkpoint inhibitor from their primary brain tumors. And this is a patient of mine that I treated at MD Anderson who had very clear tumor progression. This is a patient with Lynch syndrome and had a beautiful response to immune checkpoint inhibitor, pembrolizumab. So some of the other challenges, tumor heterogeneity. There has always been this discussion about having high tumor mutation burden. Some people have even suggested, that temozolomide-induced hypermutation might be a predictor for response to immunotherapy. But in the brain and with glioma, there's not a strong correlation between tumor mutation burden and CD8 positivity against neoantigens within the tumor. So we are in this lower category, category 2 here, where CD8 is not correlated with neoantigens. And you can see also in this example here that the anti-PD-1 or anti-PD-L1 is actually positively associated with worse outcome. And you can see this here in this Kaplan-Meier curve from trial from a study a couple of years ago, showing that those patients who had tumor mutation high recurrent glioma treated with immune checkpoint inhibitor actually did worse. And this is also sort of confirmed with another study that Mehdi Tuat did with Keith Ligon at Dana-Farber, and really demonstrating that the hypermutation is not clonal. There's a lot of subclones and subclonal mutations that are not immunogenic. And they similarly demonstrated here, you can see on the right here, that those tumors with high tumor mutation burden treated with a PD-1 inhibitor had significantly shorter overall survival. This is a publication that just came out, I think, last year from David Solomon, who is at UCSF and just recently moved to Stanford, showing that there is a very small subgroup. In his study, he found 2% of patients that had somatic hypermutation. And it was interesting, not all of them were associated with germline mismatch repair deficiency, but some of the cases were also Lynch syndrome. And these patients, again, had a very nice response to immune checkpoint inhibitor. Now, just to confuse things, Duke actually published a few years ago this idea that low somatic tumor mutation burden did correlate with a benefit to immunotherapy. They had a couple of their studies with their poliovirus, and then also some other studies with immune checkpoint inhibitors, and they showed that tumors with low tumor mutation burden actually had improved outcome. Once again, not thought to be prognostic. That association was not seen in TCGA or in the GLASS consortium data. And their sort of interpretation of this data was that there's actually immune editing within the tumor. So it's having an effective immune response, and that's why the tumor mutation burden is low. It's sort of a surrogate for immune activity in the tumor. And so we actually looked at the study that I just mentioned earlier with adding atezolizumab to standard of care and newly diagnosed GBM. And it was a small number of patients. I think we only had 6 that fit into that low TMB category, but you can see they had a much better median overall survival compared to those that had a high tumor mutation burden. So very interesting and sort of thought-provoking to have a biomarker that we could potentially use. And so with Mustafa at Duke, we're participating in the MOAB trial where patients with recurrent GBM that are have just been treated with standard of care receive neoadjuvant atezolizumab before surgery, and then go on to receive atezolizumab afterwards, with the endpoint really looking to see whether or not those patients with low TMB actually have better outcomes. The agency wouldn't let us only treat those patients with low TMB because there was a possibility that some of the high TMB patients might benefit. And so that's why both groups are actually being treated with the therapy. So one of the other big ones is the immunosuppressive tumor microenvironment. And, there's a lot of sort of studies that have looked at what could be happening both locally with autocrine and paracrine signaling in the tumor microenvironment, but also, systemic sort of factors such as steroid use. We know that there can be immune cell sequestration in the bone marrow. And there's a lot of other sort of potential issues that can lead to immune suppression. Brad Bernstein published this paper recently, sort of really going into a deep dive about what that looks like sort of geographically. And not surprisingly, there's very different levels of immune suppression and immune cells within different regions of the brain, and comparing the region of necrosis and going all the way out into areas where there's more normal brain. So very, very interesting. And I think this is really important because to date we don't really have any good therapies that are really effective at overcoming that immune suppression. There's been some trials tried, but it's been a real burden. But what I think is really interesting is this idea of neoadjuvant therapy, and I think a lot of us are trying to do this more and more, because one of the things that neoadjuvant therapy does is allows the surgeon to remove that local immunosuppressive tumor microenvironment. And I think that might be really critical, maybe why we've seen some sort of preliminary evidence of activity in patients treated with neoadjuvant immunotherapy. And then lastly, this idea of the T cell exhaustion, which I think is a real issue. Not only are there very few T cells in the brain, as compared to something like melanoma brain metastases, those cells are also exhausted. And so what can we do to overcome some of these barriers? And I think the ones that are most interesting to me are, of course, trying to modulate that immune suppressive tumor microenvironment, but also to figure out a way to deliver effector T cells, because it's become pretty clear that it's difficult to initiate a systemic immune response to antigens in the brain with some of the systemic and local immunosuppressive factors. And then, of course, the overcoming some of the limitations of that intact blood-brain barrier, which not only limit drug delivery, antibody delivery, they also limit cell delivery. I think there's, obviously been a lot of excitement about CAR T cells and some really early evidence of activity. But one of the challenges really is, can we deliver something systemically that we know will be biodistributed across the brain using intravenous delivery? And in order to do that, really having to overcome the blood-brain barrier. And there's not just sort of those typical features of the blood-brain barrier, like tight junctions and lack of transendothelial channels or lack of penocytic vesicles. But there's also, I think, a sort of a functional barrier. And this is a patient from a neoadjuvant pembrolizumab study that we did. And you can see these blood vessels are just lined with CD68 positive macrophages, suggesting that maybe there actually could be, this local barrier with macrophages preventing, T cells from entering into the brain. So I think with cells, there's really a lot of work that needs to be done about what is the optimal way to deliver cells. There's been, I think, because of the blood-brain barrier and because of some of the challenges with intravenous CAR T delivery, such as having to do lymphodepletion prior to administration, there's a lot of shift to delivering intravenous to intraarterial or to deliver intra CSF or intracavitary. And I think the challenges with that is just really knowing whether or not those cells are actually making it into the tumor. So that's where I think there's a great opportunity with focused ultrasound, which we know can reversibly open the blood-brain barrier probably for only about an hour, but can really greatly increase the delivery of antibodies. It can increase the delivery of cells as well. I won't go through this. I think the audience is probably expert in all of these different platforms. But one of the ones that we're working with very closely now is a company called Cordance Medical, which is based in Mountain View, very close to us, who's developing really a cap that would not require MR time to be able to get the sonication as it is with the Insightec device. There may be benefits beyond just delivering cells or other therapies. There's some evidence here that the ultrasound with microbubbles can also induce sort of a sterile inflammation. It's probably not enough to elicit like a robust antigen-specific immune response, but there are some good data, predominantly in mouse models, suggesting that that's the case. And you can see here that the immune priming is really effective, not just with the focused ultrasound, but combining with other types of immune therapy and leading, at least in preclinical models, to improved outcomes. And as I mentioned, there has been some studies done with anti-PD-1 antibodies and sonication, and then also this is another anti-PD-1, and then there's also been some studies looking at cell therapies, and this is a nice study out of University of Virginia looking at increased CAR T cell delivery and CAR T cell persistence when combining cell therapy with focused ultrasound and leading to a nice improvement in the outcome, overall survival. Hideo Okada here at UCSF has been very interested in trying to use or sort of better develop focused ultrasound for combinations with cell therapy. And one of the things that he's found is that increasing the ultrasound frequency just above resonance actually improves CAR T cell trafficking to tumors. And these can, sort of essentially help with the leukocyte extravasation into the tumor, which is very interesting. So there's a lot of parameters with ultrasound that could be varied that might help with delivery. So just sort of very briefly state, that I think as we're developing these therapies, one of the things that we really need to do is think about, doing window of opportunity studies to better understand whether or not our therapies are actually getting to the tumor or not. And here's, after maybe a traditional phase 1 trial identifying what is a safe dose, then there are great opportunities to do neoadjuvant studies where you can randomize to different routes of delivery, IV, IT, intracavitary, or you could even, add focused ultrasound to all of those. And then at the time of surgery, be able to better understand how well your therapy's been delivered and what the biodistribution looks like. Working with Jake Young and the company I mentioned, Cordance, and Bashkar's the founder or CEO, really looking at, could we bring this technology into the operating room and sort of learn a little bit more in real time. If you're doing a clinical trial, it takes time to actually get all of that data to be able to recruit the patients, treat the patients weeks and weeks. But in the operating room, we might actually be able to do that more in real time. And so Jake and Bhaskar and myself developed this new device that is being constructed now, where the ultrasound can be given in a very small area, and then that area can be resected. And so you can think about how you could answer questions almost in real time using that sort of technology. So last couple of slides here. Really lots of considerations to sort of optimize immunotherapy, and that's including the cell delivery as well as confirmation of what it's doing to the tumor itself. It would be great to identify early surrogate measures of efficacy. Imaging is not great, but if we could use tissue as a way to do that, I think that would be much more impactful. And then, of course, I think there's a lot of opportunities, but challenges around using device plus drug or device plus cell, and then various routes of delivery. There's going to have to be a lot of conversations around that. So just in summary, really the heterogeneity, the sort of immune suppression are really huge barriers to development of precision immunotherapy. But I think there's a lot of opportunity around the use of various cells, CAR T cells, NK cells, TCRs, and identifying patients, using various biomarkers to identify who might benefit from therapy. And then, of course, trying to improve delivery and biodistribution of treatments to the brain. So sorry to go kind of fast, but I wanted to make sure finished around 30 minutes. So thanks very much.
Thank you. Thank you so much. That was a very nice summary of all the work that's been done for so many years. If you can elaborate a little bit more on the longitudinal biopsies, which I know it's becoming something of interest. Obviously, if we had, if liquid biopsy were something that we could use this time, which is obviously in evolution, but the fact of doing multiple biopsies, that has a toll on patients. And I don't know what your experience is, if that's something you guys are already into your algorithm for managing patients with recurrences.
Yeah, there's a breakthrough cancer initiative that's being run at 4 or 5 different institutions, where Nino Kioka's virus is being injected serially in patients with recurrent glioblastoma. And I know that he's spoken about it not being too challenging, and patients tolerating it fairly well. But I think one of the advantages of that design is that they're able to sample the tissue, and so be able to learn what's happening over time, and then at the same time deliver a therapy. And I think that's what makes it attractive to the patients as well, and gets them to sign up. But I think it is challenging. I think there's a lot of interest in blood-based biomarkers, as you said, and I think if focused ultrasound, if the Liberate trial from Insightec turns out to be positive, that could be very interesting, and may change the paradigm of how we can follow tumor evolution over time.
Yeah. Any question, Antonio? Do you have any comments, or Arya?
No, thank you, Dr. Groot, for an awesome presentation. I know you talked about immune checkpoint inhibition, given in a neoadjuvant fashion for GBM. Any thoughts as to, is anyone trying to do ultrasound? I know you talked about the cap prior to resection.
Not therapeutically, no. I would love to do that study. Like, we actually wrote a study to do immune checkpoint inhibitor plus focused ultrasound in the neoadjuvant setting. Actually wrote that 5 years ago, but weren't able to ever get it funded, and so didn't pursue it. The other thing that I think people are doing is moving into the newly diagnosed setting as well. So doing there's a trial called the Giant trial that we're doing with Duke and some places in Australia, looking at triple immune checkpoint inhibitor in newly diagnosed patients. So sort of also neoadjuvant. So that's where I think, you really have to have tissue confirmation with a biopsy and then give the therapy and then wait a few weeks and then take the tumor out. So it's complicated. And I think in the newly diagnosed setting, it's where we need to move for most of our therapies, but it also makes it really hard on the patients too.
Hey, Dr. DeGroot, Antonio, one of the residents here at UT Health Houston. I was just wondering, we heard over and over these talks from prominent neuro-oncologists about the dead horse theory and immune checkpoint inhibitors. So what is your perspective in how to avoid going to these phase 3 clinical trials that obviously fail, and rather knowing an endpoint before that we can consider for these therapies?
Yeah, it's a topic near and dear to my heart. There's, I think that the only thing, well, I guess the main thing to do is really to de-risk those later stage trials as much as you can. And I think the first thing that you have to do is actually understand if your therapy is doing what you think it's doing. And the story behind the immune checkpoint, behind the PD-1 drug was, in the phase 1 study, they actually had some patients who received the immune checkpoint inhibitor in recurrent disease, and they had lots of, inflammation. They had, contrast enhancement. They got taken to surgery and there was nothing there, no tumor. And so the assumption was that, was having a true, immune effect against the tumor. And that just turned out not to be the case. I think we've all seen, examples where, it's not, you're not getting to sort of the core part of the tumor where the tumor is. And so that was really deceptive. And so I think, you have to make sure that really you're able to prove that your therapy is doing what you want it to do. And then the second thing that I think you can do is you can do a randomized phase 2 to 3 design where you're actually able to sort of stop if you're not meeting the primary endpoint of your study instead of going all the way to phase 3.
Well, this was great. Thank you so much for all this wonderful information. And as said before, it's going to be recorded, and please go ahead and claim your CME. And I truly appreciate your time, Dr. DeGroot, and hope to see you soon. Thank you, everyone.
Thank you.